Well, hello everybody, and welcome once again to one of our discussions with senior health and care leaders from across the UK and beyond. Today, we're going to be talking patients, all things patient, from patient empowerment, patient engagement, industry involvement with patient, and no better person to join us on that on our journey for the next 15 or 20 minutes than Mark Duman. Mark, many people watching, listening to this will know you, but just give us the quick bio and your credentials for this.
Yeah, thank you very much, Richard. I appreciate the opportunity and ABHI embracing the discussion about patients. As you say, things are changing. This is something we need to start doing more of. So first and foremost, I'm a patient with type 2 diabetes for the last 10 years, currently in remission as I try and hold in my gut. Type 2, so I have the advantage of perhaps with lifestyle changes, changing some of my disease state, not like everybody. I'm also a retired, in inverted commas, or non-practicing pharmacist, and I am an embarrassed management consultant who basically sells patient engagement, digital health, and market access solutions to life sciences and beyond. And I am working from home today, as many of us still are. And if the dog goes mental, I've tried to keep her quiet, but it will add to the realism of working from home. So I've closed the doors, I've tried to keep her quiet, but she is an animal after all and doesn't take instruction, pretty much like my children.
Well, let's hope she does today, because she might set mine off, and mine's quite loud too. So, but anyway, actually, one of the first policy documents I can ever remember reading was, whenever it was called Putting Patients First. And the riposte for a lot of people at the time, including Prince Charles, as I remember, was where on earth have we been putting them up to now? Mark, I know you've got some fairly forthright views on patient engagement, patient empowerment in what is still a very, very heavy medicalised health and care system, not just in this country, but throughout the developed world. Maybe give us some thoughts on that.
Yeah, no, and thank you for that introduction. I think, I as a pharmacist, used to only talk about medicines, and often I didn't necessarily know what that medicine the patient was taking it for, what the indication was. My whole focus was, have you taken your antibiotics? Do you take your inhaler properly? And never really saw either the condition or the disease behind the medicine, or indeed the person behind the patient. And my own journey with diabetes was, for the first 8 years, everybody talked to me about LDL and BMI and HbA1c and every other clinical acronym you can think of, which fortunately I'm health literate as a professional and understood them. But it didn't resonate to me as a patient. It didn't mean anything. So I continued to have the bad lifestyles. And then one morning, after having, I think, had a tub of ice cream for breakfast, sitting with my then 8-year-old daughter, I suddenly thought to myself, if I continue this way of eating and this lifestyle, I might not be here at your wedding, please God, in 10 years, 12 years, whatever years time. And even if I am there, I may not have my eyes because of retinopathy. I may not have my kidneys because of nephropathy, et cetera, or even my feet because of ulceration. So all of a sudden, that islets of Langerhans, that drug receptor theory, knowledge switched, and I began to think a little bit about what's my personalized care plan. And I don't think we talk the language of patients and of people. I think we talk the language of medicines, of devices, of clinicians. So there's something for me that says we really need to turn some of the conversations on our head and say, not necessarily, Mark, what's your BMI? But to say, Mark, you're 54 years of age. I had my birthday a couple of weeks ago, and dare I say, long may they continue. But if somebody said to me, your heart age is 66, your brain age is 72, all of a sudden, I think to myself, okay, hold on a minute. I need to eat better. I need to sleep better. I need to do some mindfulness. I think when we begin to talk what I'd call a more consumer, a more marketing, a more personal language, we can begin to make healthcare and medicine a little bit more approachable. And to me, that's what's missing. We still talk a language of medicine. We still talk about devices. When patients don't take medicines, what do we say? You're non-adherent or you're non-compliant. And I think that's something that is, again, a little bit, let's pass the blame on to the patient. So for me, a couple of things. Can we begin to see the person behind the patient and behind the condition. And there's a whole lot of work to do around that. What are people's illness perceptions, their medicines beliefs, their health and their digital literacy and their degree of motivation? These, what I'd call vital signs, are just as important as your clinical parameters, dare I suggest. How do we nudge that patient to take a little bit more responsibility for their own health? Or in my case, where I've got diabetes in remission, thankfully, go to my synagogue and say to the other 20, 30 people in my synagogue, gently and carefully, hi, I've managed to lose a couple of stone. You've got to be very careful how you do this, but, would you be interested? How can I help you, et cetera, et cetera. So taking that community and that caregiver responsibility to a different level. And that really is about health coaching. And I'm not sure how many clinicians out there, they're great caregivers, most of them, but they don't know how to coach. And I remember speaking to a pulmonologist, as they call it in the States, and he said, Mark, it took me 10 years to pluck up the courage. I always ask the question, obviously, to patients, do they smoke? But I didn't have the courage or the knowledge or the skills to say, how do I coach them to start quitting and giving up? And it took him a decade to begin to learn how to do that. So I think for me, patient engagement isn't just about, hi, we've got somebody on a policy document and we've done a bit of consultation, but it's really about how do we embrace a fully engaged public? And just as you can hear, I can wax lyrical. For those of you who are as old as you and I are, if you cast your mind back 20 years to the Wanless Review, may he rest in peace, back in 2002, Derek's review of the NHS showed that a fully engaged public, not that that's easy to do, would save £30 billion at that time, 2 decades ago, which was the very deficit the NHS then faced. So there is a monetary element to this as well. So we don't just need, dare I say, all-party parliamentary groups for medicines access and market access, which are important, and patient access. We also need to think about, in addition to a medical model and a device model, how do we embrace that patient to take more care, which might well include better use of a device and better taking of medicines. But to me, it has to come from that patient activation, the motivation, the health psychology and the behavioural side first.
That's really interesting, Mark. And we could probably have this conversation for the rest of the day on, Wanless and previously and the current initiatives around that and all this kind of nudge policy initiatives. But I think you brought it nicely onto the next little bit of that is industry's engagement with patients. I hear it a lot. What are we doing with patients? We need to do more with patients. So this is something I know you're very passionate about, Mark, and you helped a lot of companies with this. Just give us a sense of where you think we, some examples maybe, or some thoughts about what good looks like in industry and get patient engagement, and then some thoughts around that would be really helpful.
Yeah, so I think first and foremost, there's a little bit of a myth that says we can't talk to patients. You can in the United States, and you can do direct-to-consumer advertising, dare I say. I'm not suggesting in any shape, way, or form that's necessarily a good thing or a good model. I find it actually devalues medicines, speaking both as a consumer, as a patient, as a pharmacist. But putting that particular approach, which I believe is unique to the US, although I'm not sure, I don't know if New Zealand rescinded their approach, but I think it's one of the only countries in the world where you can do that sort of direct advertising. In the medical device industry, we can do a little bit more of that industry, which is interesting. And I don't think we take full advantage of that. Again, not from an advertising or from a marketing perspective, but from an engagement perspective. So for me, really, there's about, number one, you can communicate with patients. You just have to do it within some cases regulatory boundaries and in a non-advertising way. And I think what we need to be doing is to really think about information as a therapy. What's our responsibility as industry to give patients a full approach to what we call shared clinical decision making? So again, we're getting to the age, dare I be so bold, that if we look a little bit lower behind what you can see in the camera, we perhaps begin to think about prostate enlargement, right? Now, without putting too fine a point on it, there are 3 broad approaches to prostate treatment. There's watchful waiting, because maybe the symptoms aren't difficult enough. You wake up in the evening and you're not working perhaps anymore, or please God, will be retired soon. But, so it doesn't disturb your day and all the rest of it. So watchful waiting is fine. You can go for a medicines intervention, or you can go for a medical device, a surgical intervention. Now, all of them, broadly speaking, have different outcomes, different risk-benefit ratios, but really that decision should lie to me. That should be a decision, and I should be empowered with my caregivers. Is there issues of sexual impotence, and dysfunction possibly as a side effect, and am I married? Am I not married? Am I in a relationship? These are very personal decisions, and I wonder if the information that we produce and we support patients with gives them one option and supports our particular intervention, or really truly gives them the whole array. So first and foremost, we can communicate with patients, and let's do it in a unbiased, promoting shared decision making. I think secondly, there are a myriad of ways to involve patients in the life sciences industry and right across the asset life cycle. So from R&D and looking at clinical trial protocols to looking at health technology assessment and taking into account patient preferences and patient quality of life markers, not just clinical ones. We've touched on that a little bit earlier. Right the way through to patient support programs and disease awareness campaigns. And as I've said, the educational material that goes both to patients but also to healthcare professionals. I remember when I used to work as a pharmacist and I didn't know a particular medicine particularly well, I'd run off and read the patient information leaflet, and quickly go, oh, right, that's what it does, that's what it does. In the old days, I used to hide that in the dispensary. In the future days, when I was practicing, you could actually sit down with a patient and go through it with them. It wasn't, you couldn't know. When I remember qualifying back in 1990, I pretty much knew most drugs in the British National Formulary. Nowadays, it's impossible. So I think that shared decision making and me being the font of all knowledge has changed a little bit. So there's loads of ways to get involved. And I think if you look more, I'd say, at pharma than at medical devices, I think we're beginning to see a real embracing of across that asset life cycle. I've been talking to Janssen. They've been doing a lot of stuff in the R&D side. Ipsen, I think 100% of their publications now have patients on board. Novo Nordisk have what's called a deep panel in their diabetes franchise. I'm a member of that as a patient. It's called the Disease Experience Expert Network, i.e. we are living with lived experience of the disease. We can tell Novo Nordisk, who are experts in medicines and devices, what it's like to live with a condition. They don't know, and medics, dare I say, don't know. We are the ones who can provide that insight. Some companies are setting up patient academies to teach us about HTA. There's UPATI, people will have heard of, which again is very focused on how medicines are made, and they're beginning to look at medical devices and beginning to broaden that out. So there's a myriad of things happening, and I think, we just need to get away from this. Oh yeah, we've got a couple of patients. There's a wonderful initiative that you can sign up to for free and self-assess called Patients Included. And what Patients Included says was, it started with a doctor in the Netherlands who turned around and said, I'm fed up going to conferences that say what your policy document said, we put patients first. And there was no patients at the conference, despite everybody talking about patients. And let's be blunt, companies like Forbes, who talk about doing the most renowned healthcare conference in the world, JP Morgan, Wired Health, all these great brand names, broadly speaking, still don't have patients speaking at their conferences, never mind having patients actually shape their conferences. So as we talk about this whole patients at the centre, patients first, nothing about us without us, there's an awful lot happening about us without us. So when you say patients first, it's not first. Let's be blunt. If we look at some of the numbers, 50% of my healthcare outcomes are about the environment I work in. 20% is genetics, but 90% of the spend is on access to health. And I just don't think we're spending enough time or money, dare I say, on prevention, on self-care and self-management. So we need to do a little bit more. I'm embarrassed. Oh God, here we go. You ready? I'm embarrassed a little bit to be a pharmacist where 50% of the medicines that we are often the last point of contact in dispensing don't get taken as prescribed. What other industry would accept a 50% failure rate? Microsoft Teams, no. Wi-Fi, no. My phone, no. My train fare, no. So what, if we're supposedly in a value-based, outcomes-based healthcare system, why are we happy or not with a 50% failure rate? It needs to change. So I look forward to the day when, sadly, I think it's going to have to be regulatory and payer-driven. We have, again, in my world, medicines, and again, more possibly in your world, but we begin to have people turning around and saying, number one, the patient needs to take the product. and use the product. And number two, I want to see, having taken the product, the same outcomes as you suggested in your clinical trial submissions, and then I'll pay you. That's cash on delivery, not the current model, which is cash on non-taking or cash on non-delivery. So sorry to be a little, rebellious, challenging, whatever, but it's not just about getting drugs and medicines and devices onto formularies and getting accelerated access reviews. It's about getting them into and used by patients to improve outcomes, reduce hospitalizations, all the rest of it. And the most effective medicine and medical device in the world is the one that's actually taken. Whew.
So you mentioned some companies that do it well. You mentioned pharma, of course. There's probably a resource element there and a bandwidth capacity. But if you were going to mark our homework as a sector, given you could argue, I'm not a medical device user and I haven't got an implant or anything, but I am full of pharmaceuticals. You could probably argue that there is a more intimate relationship with the device than pills. Where do you think we're at as a sector on this?
So, yeah, don't get me wrong, I caught up with a colleague at your dinner the other month. And again, thank you for that invitation. I very much enjoyed that evening. And a colleague that I know, funnily enough, ex-pharma, who's now in Coloplast, was there. And I think they're doing some great stuff. And that's even more intimate, dare I say, with stoma care than even carrying a few pills in your belly or injecting a couple of times a day. Every time you wee or etc. We know the detail there. So that is incredibly intimate. And I think they're doing some really great stuff. So I'm not excluding the entire sector, but I think broadly speaking, pharma, yes, they have maybe more resources, maybe less commoditized. But if I look across pharma, ABPI versus ABHI, so to speak, and your members, it seems there's broadly speaking more patient engagement in pharma than there is in medical device side of things. And my little bit of a challenge to ABHI is, dare I say, what are you going to do to maybe encourage your members to embrace that? Again, there needs to be a return on engagement. There needs to be some impact around this. But, I think I've just seen Janssen, for example, has joined Catherine Caparella, their chief patient officer. She doesn't go by that title, but head of patient engagement, I think, is now across all three divisions. So she's now joined Janssen from a pharma medicines perspective with J&J Consumer and J&J Devices. So we are beginning to see an amalgamation that is great for me as a patient or a person. So I think there's a little bit more to do in your industry. We're setting up a sort of informal group. We had a meeting, I think, in March, and we might be doing one again in May, just to begin to raise the topic and see who's doing what, how can we share good practice. So again, my urge to ABHI would be, maybe have a think about it. Can we get patients a bit more into your stuff? And, Ellie, your public affairs lady, was brilliant. When we talked about one of your innovation reports, I said, the medical model does 2 patients, the charitable model does 4 patients. We're all talking about doing with patients, but can we also do from patients? And she was like, what do you mean? I said, well, look at patient innovators. Michael Sears, God bless him, and I really miss him, developed a device to help stoma users. We had Tal Goldsworthy, who NHS England had been showing has Marfan syndrome and developed a medical device for his heart. So let us patients in. There's a lot of stuff we can do once you look at working with us. And then there's obviously real world data and all the rest of it. So let's not just do with patients, let's do from patients. Let's have them co-create events and speak at events. Let's really, as you said at the beginning of this, let's put them first. That's key.
Right, thanks, Mark. It's a good challenges there for us all, actually, and I'm sure they'll be well received. Just to finish off, then, so people watching, listening to this, thinking, okay, yeah, that's a fair challenge. Where would they give just a few tips on where would you start? Where would they start their journey to being better engaged and more patient centric? Dare I say it?
Yeah, a couple of things. One, when was the last time you walked through a pathway or the pathways that your patients go through? Have you gone to a GP surgery, a hospital, a diagnostic centre? What's it like to actually walk through that patient pathway in that patient journey. So walk the shop floor, as we say. And I don't mean the shop floor in a carry the bag sort of rep perspective. I just mean see what the patient journey is like from a personal experience point of view. Have to wait in queues, whatever it may be. I think secondly, what patient insight do you already have in the company? Because often people have done stuff, but it sits sometimes within brand or within therapy area silos. And to be honest, whether you've got diabetes, cancer, kidney issues, cardiovascular issues, some of the core chronic disease elements are the same. You know, there's diet, there's activity, there's medicines, there's devices, there's some real core components that you can still share across industry. So I think get out there, feel what it's like, see what you're doing, try and get some more patient insight, and don't be scared to talk to patients within that regulatory insight. One of the things we're doing a lot more with companies, we've done it with Roche, with Pfizer, with Janssen, we've even done with digital health companies, is set up what we call patient sounding boards and patient councils, not ad boards, which are, you know, meet once or twice, but actually compliance-wise, bring together a group of patients that sit for, you know, 2, 3, 4, 10, 5 years, whatever it is, and change, but you know, at therapy and above therapy level, where you've got a bunch of people you can go and talk to. You're not having to go through compliance and set it up all the time, but you've the same way you will go to business advisors and you say go to healthcare professional advisors and payers and prescribers and policy advisors and try and understand the market from their perspectives. Why not do the same with patients? So to me, not that I've been very good at this on this call, but listen with both ears. So listen twice as much as your mouth. You know, if as a creationist, I believe you were created with 2 ears and 1 mouth, maybe that's an indication of listen a little bit more than you talk.
Well, great, thanks. You weren't here to listen today. You were here to talk. I was here to listen, and that I think quite a few of us who were sales guys back in the day will remember that advice. Mark, this has been great. I know you've done some fantastic work in this. When we put this out, we'll send some links to illustrate what you do and the ways you can maybe help some people on the call. But it's been great to talk to you. We must do it again. We will do it again, I'm sure. But thanks very much for your time, Mark. And I'm really glad to hear you're doing well on the diabetes front.
Thank you. And thank you to you, Richard, personally, to the ABHI for all you do and all you want to do, and especially to Bonnie, my dog, who thankfully didn't start up.
And Jeremiah as well, who's been very quiet. I think my wife's got it locked somewhere.
Fantastic. Have a great weekend, and look forward to the next time we meet up in person.
Yeah. Thanks, Mark.
Thanks a lot. Bye-bye.